Hi, this is Jen doing the case study for week 6. We have a 60-year-old male with a past medical of a 66 pack year smoking history, COPD, rheumatoid arthritis, and cataracts presenting to the emergency department from his long-term care facility, complaining of a week-long increase in dyspnea and cough with sputum. We have allergies of oxycodone and some home meds. The cough medicine that they gave him is not included in that home med list, and that would be helpful to know. Other things that would be helpful to know would be if he'd ever been hospitalized for a COPD exacerbation, if he's got a family history of cancer, and I would like to know why he's at the long-term care facility. Why is a 60-year-old man needing long-term care? It'd also be good to know if he's had any surgical history, especially related to the lungs. So we didn't have a lot in that case study in terms of findings and things like that. So things that I would want to know about are if he's got any swelling or other redness, irritation, lymphadenopathy in his HEENT exam. Do we have any other reasons to suspect upper respiratory, anything like that? I'd want to have some lung sounds and see how that is. I'd want to know if he's got orthopnea. How many pillows does he need to sleep on? Is that worse or better than normal? Let's see. I think those are the most important things for me. I'd also like to know if he's got any Janeway lesions or anything that might have a cardiac implication. I'd also like to know if he's feeling more weak than normal. So objectively, he's tachycardic and tachypnic. He's requiring 3 liters via nasal cannula. I'd like to know if he normally requires oxygen. And I'd also like to know his BMI because he does have a complaint of weight loss, and so I'd like to know how significant that is. Yeah, so pretty much I want to know more on exam about his lungs, about his circulation, and a little bit more of that past medical history. I'd really want a chest x-ray, and I would really like to know if he has a positive respiratory panel anywhere, what his SED rate is. I'd like a UA, a D-dimer, and an eosinophil count, as well as a TSH and free T4, although I don't really think this is hyperthyroidism. So the abnormal sign or symptom I'm tracking at first is tachypnea. I'm thinking likely COPD exacerbation given his history of COPD. Can't miss PE and ARDS and sepsis. Less likely would be pneumonia or neoplasm, although that could change with the chest x-ray. It could easily be a pneumonia or a neoplasm. Unlikely is heart failure, and I'm just saying that because he doesn't have a history of heart failure, and he doesn't have any edema. So the tachycardia is somewhat similar. I think it's probably a neuroendocrine compensation for his hypoxemia and his mild hyponatremia. But again, the can't miss for that would be the PE, the ARDS, and the sepsis. Less likely would be an endocrine disorder such as hyperthyroidism. Unlikely still the heart failure and the MI. His ECG findings don't indicate an MI. He's not having chest pain, and his troponin is not exciting. I don't think he's having an MI. And then the hyponatremia is probably pre-renal, so that's likely, and it's probably related to poor PO intake since he's having such a hard time breathing. Probably he's mouth breathing, so losing more fluid. Can't miss, it's a pretty mild hyponatremia. I don't know that there's, you tell me, maybe there's something. Less likely SIADH, and unlikely would be intrarenal AKI. It's just not really presenting kidney, it's respiratory. And so my assessment is that we have a 60-year-old man who lives in a long-term care facility with that past medical history, tachypnic tachycardic with a 3-liter O2 requirement, unaware of ill context, white blood cell and lactic acid within normal limits, slight hyponatremia noted, D-dimer, sed-rate, chest x-ray, TSH, and free T4 are all pending. And then how would I incorporate patient-centered care and shared decision-making into documentation? Well, the AHRQ has a set of tools that they've developed to do just that, because they found that incorporating patient-centered care has many benefits, including higher patient satisfaction, and decreased cost and more patient compliance, and better outcomes. And so they put together a toolkit. One of those tools I thought was kind of easy because it follows an acronym. So SHARE, S being for seek the participation of the patient, H being helping them explore their diagnostic and treatment options, A being assessing your patient's values and preferences. So that, to me, implicates being sensitive to those things and respectful. And then R is for reaching the decision with your patient, and E would be evaluating your patient's decision. A brief discussion of this can be included in a SOAP note. Some of those are actually templated into different facilities' notes, I've noticed. But an example might be patient was actually actively involved in discussing diagnostic findings, treatment options, and personal implications. And patient elects to pursue X treatment options. I think that kind of hits it. I had the discussion, we talked about it, I respect their preferences and their values, and here's what we decided to do together. My 2 open-ended questions. One of them is a repeat because I really would like to know where the best go-to resource is for finding guidelines for best practices, first-line treatments. There's different organizations for different disease processes, and it'd be nice if there was like a repository where all of those were kind of found or easily found kind of together by diagnosis maybe, or by organ system or something. I haven't found it. If you know where it is, I would love to have that resource. And then my second question is, what would be your first intervention for this patient while the additional labs and imaging are pending?